Good afternoon, everyone, and welcome. My name is Vanessa Monahan, and I'm a Senior Director of Marketing for Boston Scientific. On behalf of our team, I'd like to begin by thanking Dr. Veredarajulu and Dr. Hawes and the entire Florida Live Endoscopy team for pulling together such a special and incredible event. The theme this year, A Generational Odyssey of Endoscopy, reflects a rare opportunity to celebrate the ideas, experiences, and innovations that has shaped the field to what it is today, and while also creating an exchange of ideas across generations that will define where the field will go next. For Boston Scientific, endoscopy has long been a place where innovation fundamentally changes what we can do for our patients. We are proud to partner with physicians who continue to push the boundaries of the field, whether it is through technology, clinical research, or education. This meeting is a celebration of that same spirit. Innovation built on the experience of one generation and passed on to the next one to define what's next. We are fortunate to have 4 distinguished international faculty members with us this afternoon, as well as 2 incredible moderators. And I'll start to introduce them one by one. Professor Costamagna from Agostino Gemelli University Hospital in Italy will begin the session talking about biliary and pancreatic stenting, lessons learned by a master. Professor Rösch from University Hamburg-Eppendorf in Germany will then discuss Therapeutic US, present status, and look toward the future. Professor Bourke from Westmead Hospital in Australia will address endoscopic mucosal resection in the colon, applications, and current best practices. And Professor Tajiri from GK University School of Medicine in Japan will conclude with endoscopic imaging, present and future. And of course, I'd be remiss not to mention our 2 expert moderators, Dr. Greg Haber and Dr. Hawes. It is a privilege for Boston Scientific to sponsor this event and this remarkable educational event. So please join me in welcoming our panel and expert faculty.
I have the pleasure of introducing our first speaker, Dr. Guido Costamagna. Certainly, there is no one better suited to talk about stenting than Guido. Of course, he learned his pancreatic world from Michel Kremer, whom we honor for what he did for pancreatic endotherapy going back many years. But I think what reminds me of Guido is one particular paper in which there's an image of, I think, at least 6 10 French stents coming out of a biliary tree, which was the challenge to the self-expanding metal stent. So I think there's nobody better suited to talk about stenting than Guido. But Guido has done amazing things for endoscopy. He established a European endoscopy training center in Rome at least 20 years ago, 24 years ago. He had a wonderful program that he carried out at Gemelli Hospital for many years. He's just legendary and iconic in Italian endoscopy, European endoscopy, and the World Society honored him as well this year. So it's such a pleasure to have you at the podium, Guido. Thank you.
Thank you very much, Greg. But I have to thank, first of all, not you, but Shyam and Rob for taking me here and giving me the opportunity to see so many friends, old friends. And so it's really a pleasure to be here, Rob. Thanks. And thanks, Shyam. I modified a little bit the title of my lecture. I removed the master. I'm surely not a master, but I learned a lot of lessons in these years, and I will try to sum up in the next minutes. After my retirement as an academic, I work in this hospital. This hospital is on an island, the only island of the Tiber in the center of Rome, and is active since the mid of the 15th century. And today, this is the hospital. We have been renovating completely and the interior of the hospital because we cannot touch the exterior. And we have really state-of-the-art technology now. And it's a pleasure for me to continue teaching in this hospital. This is a drawing that is the first time that I show. The drawing is from 1978. It was given to me by André van Latem, and this was the idea of my mentor, Michel Kremer, for placing a stent. And as you can see, it's interesting to see that already the idea of having flaps to avoid the dislocation of the stent was there. The problem is that at that time there were almost no guide wires, and so they tried to put the stent twice in Dinan, and they failed. And for that reason, the first one who placed the stent is here, is Nip Soendra, published in 1979. And with this stent cut in the Teflon, homemade, something that today will bring to you to jail in 5 minutes, and personalized in boiling water. So 1979. And it's extremely interesting to see that already 4 years later, Dr. Frimberger published the idea of a metallic expandable stent, a spiral stent. But then, as you know, it took at least another 10 years to have the wall stent, and then the wall flex, and then all the other expandable stents. What did I learn in these years? A lot of things, and I will try to sum up very quickly. In the terminate biliary stricture, what to do, hilar malignant strictures, postoperative biliary strictures, stent for unretrievable bile duct stones, and in benign biliary and pancreatic strictures in chronic pancreatitis. And then a couple of comments about the technique of multiple stentings and what to do with proximal migrated stents. In the terminate biliary stricture, usually hilar, you know that the pool sensitivity is very low, and brushing biopsy or even biopsy under echoendoscopy, visual inspection with cholangioscopy is never 100%. So if a final treatment has not been established by a multidisciplinary team, never use metal stents, even if fully covered and potentially retrievable. These patients, if they have a primary tumor, may be operable, and if you put stents, you manipulate, you induce contamination, and these patients, you may change the natural history of the disease. So do not touch this patient. Jaundice per se is never an emergency. You can wait. Only if septic patients are emergencies. Highly malignant strictures. I think that, but everybody thinks that in preoperative treatment, you should prefer plastic stents. For palliative treatment, preferred uncovered metal stents, but with a question mark, because today this is debated. Maybe plastic stents may be also suitable for this treatment. And if the stricture is in the classification of Bismuth-Corlett more than one, which means the main hepatic confluence has been interrupted, multiple stents are indicated. I prefer side-by-side compared to stent-in-stent placement of metallic stents, and I will show you why. And if multiple stents are needed, prefer the terms complete versus incomplete compared to monolateral versus bilateral drainage. Why? The main problem in these patients with complex strictures is that very often they don't die because of the tumor, but because of septic complications in the undrained sectors or segments during the evolution of the disease. And therefore, I think that complete versus incomplete is more important than unilateral or bilateral. Look, one stent in bismuth correlate type 2 means unilateral and incomplete. 2 stents mean complete. So the risk is reduced, the risk of septic complications. In type 3, more difficult, if you place 2 stents, you may be bilateral, left sectorial right, and incomplete, or unilateral and incomplete. So in both cases, you have not a complete drainage. To have a complete drainage in type 3, you must do a bilateral and complete with 3 stents. This has been discussed also by the SGE some years ago, and the indication is that future studies should try to use the term multisectorial stent placement rather than bilateral stent placement. And if you look at the literature today, bilateral and unilateral are still used in most of the papers. How to stent? Antegrade injection? No, never, because if you inject and you're not able to drain, you induce cholangitis. So the technique is, in this case, for instance, which was also a very difficult case with type 3 and Biliary 2, previous resection of the stomach, you see that the first stent is inserted only after a pacification of that sector, then the left, and then the remaining right sector, after only passage of a guide wire and selective opacification. Try to avoid undrained and opacified bile ducts to avoid cholangitis, which is very probable, and complete with percutaneous access if you are not able to place a second stent endoscopically, or today also with hepaticogastrostomy under US control. Why side by side and not stent in stent, which is more popular in Asia? Because very often, due to the prolonged survival of these patients, you will be obliged to treat some dysfunction of these stents. And very often a dysfunction is not due to ingrowth or to overgrowth of the tumor, but simply by sludge formation inside the stents. And even if stent by stent and stent in stent have a similar clinical performance, the revision of malfunctioning bilateral metal stents is much more easy with the stent by stent technique, 92% compared to less than 70%. So if you place multiple stents, try to place it side by side at the same level in order to be able to recannulate these stents and to clean them. We also showed that if we retreat very early these patients with septic complications due to malfunction, the survival is significantly prolonged. These are a series published some years ago by our group on more than 100 patients with multiple side-by-side metal stents. Now, postoperative biliary stricture. This is very interesting because once upon a time, this unfortunate disease, due very often to a mistake during cholecystectomy, was treated only surgically. We developed what we call the aggressive approach. Aggressive approach means that we were not staying to the classical 2 stents technique described by the School of Amsterdam, by Kees Huybrechts and colleagues, but we tried to insert as many stents as possible in order to completely solve the stricture. You see, after 2 stents, there is a remaining stricture. So we placed 4 stents after 3 or 4 months. And then we increased the number of stents to 6 in this case to obtain a complete resolution, morphological resolution of the stricture. And in fact, in 25 years ago, in the same issue of gastrointestinal endoscopy, there were these 2 series. The first one published by Jacques Bergman, who is here in front of me today. And the second one with our attitude a little bit more aggressive. Why we decide to be more aggressive? Because in the first series published by the group of Amsterdam, I realized that some of the patients, of the 20% of the patients that had a relapsing stricture, had a very early relapse of the stricture after a few months. So I suppose that this was to sort of under-treatment of these patients, and that's why we decided to increase the number of stents. And in these 2 papers, you see that from 20%, the percentage of recurrence was only 1 patient in our series. Of course, we were, as usual, too much optimistic. But in any case, by following the same cohort of patients for many years, here a very long-term follow-up at more than 13 years, we had 10% recurrence of the stricture compared to the 20% with 2 stents. So I think we were able to improve the results of this technique. And all these patients with recurrent stricture were retreated endoscopically with success. More recently, we published another series only of post-cholecystectomy biliary strictures, more than 150 patients, and with a follow-up also quite long, more than 10 years, and we had the same results, so about a little bit less than 10% of recurrence in this cohort, and all these patients, again, could be retreated endoscopically. Why not using metal stents in these cases? But I think for 2 reasons. The first one is that the post-cholecystectomy strictures is usually quite high in the bile duct, and if we impact a metal stent in the confluence, in the main hepatic confluence, you can get very easily hypertrophic reaction of the tissue, and this is not good, of course. And the second reason is that having this stricture very high in the hilum, the risk of dislocation is quite high. And effectively, if you look at this series, which was part of a larger study that we did with metal stents in benign biliary strictures, there was a spontaneous migration of more than 15% in this group. And the structural resolution at the end of indwell was only about 70% with metal stents. And if you look at the long-term results of this series of 18 patients, only 60% of the patients were free of stricture at 5 years follow-up. So probably the fact of placing multiple plastic stents during the time makes what I call a sort of physiotherapy of the strictures, a massage of the strictures, and not an abrupt dilation. Every time you dilate abruptly a stricture, you create a trauma and you create reaction. And that's why probably the idea of increasing progressively the diameter of dilation is a better idea. The same may be said about post-liver transplantation anastomotic strictures. Of course, here the place of metal stents is probably larger because the part of the bile duct above the stricture is always quite long. And you see here a metal stent placed in this case. Nevertheless, 23 days late, the patient had pain and the stent was dislocated. So Again, we treated these patients with multiple plastic stents. I think at the end he had 4 or 5 plastic stents with complete resolution of the stricture. This problem of dislocation is probably solved by this new design of stents that is proposed by Boston Scientific on a fully covered wall flex with an anti-migration system at the proximal end. And also increasing the features of radial forces to conform the wall flex to the duct. We will see. In any case, if we look at the literature, and this is a meta-analysis of different studies, the two techniques, multiple plastic versus fully covered metastents in this kind of anastomotic biliary strictures has the same results in terms of resolution. But if you look the stricture recurrence at the long term, these data favor the use, again, of multiple plastic stents. In our retrieval bad duct stones, only a couple of words. I prefer to place 2 stents if I'm not able to remove the stones and waiting for some lithotripsy, either extracorporeal or intracorporeal. And I prefer to place 2 stents just because 2 is better than 1. I have no other explanations. In benign biliary and pancreatic strictures in chronic pancreatitis, that's another important place where endoscopy may be useful. This, again, is part of is a study that we did with a group, also the group of Nagi Reddy with Mohan. If you look at the results of biliary strictures treated with multiple plastic stents versus fully covered metastents, the stricture resolution is similar. The number of ERCP is, of course, less for metastents. Adverse events are more or less the same. Which means that probably most of these cases may be treated with metal stents, with fully covered, of course, metal stents, but the option of multiple metastents is still there. Pancreatic strictures in chronic pancreatitis. These are very old data, but that show that the results after 6 months of a large bore 10 French pancreatic stent had a clinical success of only 30 to 50% after 3 years. The stent left inside for a longer period may achieve better results, 60 to 70%. We also tried this idea of multiple plastic stents in the pancreas, and in this series published 20 years ago, of 19 patients with unrelenting strictures, we could increase the positive results close to more than 80%. However, these data are not very clear, and there are data also coming from the group of Brussels that show that it's not a good idea to insert immediately multiple plastic stents because most of these patients may be treated with a less aggressive technique. By the way, if the stricture doesn't resolve with one single plastic stent of the large bore plastic stent, you can increase with the same idea as in the bile duct with multiple plastic stent achieving better results. What about metal stents in the pancreas? Unfortunately, until now, we don't have very good results. Even this study, multi-center study published 3 years ago, with fully covered metal stents produced for the pancreas with very flexible, the results were not very satisfying. And therefore, I think that today metal stents, even if fully covered and removable, should not be used in pancreatic strictures unless in the setting of a trial. So to sum up, in the pancreas, I think that you should start the endoscopic treatment with one large bore, 10 French stent for at least 6-12 months. If the stricture persists, you can increase the number of stents up to 2, 3, or 4 for at least 6 months. Remember that if you have placed 2 stents for 6 months, it's almost always possible, at least in the bile duct. It's more difficult in the pancreas. It's always less possible to increase the number. Always. So it's not a problem, really. In the pancreas, no, because you have the parenchyma around the duct. But this is another story. But usually you can place 2 or 3 stents for another 6 months to get better results. I do not suggest to use fully covered metal stents out of clinical studies. And in case of failure, endoscopic retreatment is almost always possible. 2 words about the technique. About multiple plastic stenting, one trick is to start always with a longer stent because it's the first stent you place is the one that has higher risk to be displaced by the friction of the second one or the third one. So take a long stent, even if it's not necessary. When you place the second, the third, and one, change the axis of the insertion during placement in order to avoid the friction with the first one. And my suggestion is, because I saw some experience where stents are only added. No, you have to remove all the stents, clean the duct. There is always a lot of sludge forming, even if the patient is totally asymptomatic. So what I do is to remove the stents, do not inject contrast. You know the anatomy from previous ERCP or MRR. You can cannulate easily, blindly, the different sectorial branches with a guide wire, pass a balloon, clean completely the duct, and then place new stents and increase the number. For proximal migrated stents, forget Dormia basket, forget guide wires, balloons, take a rat tooth forceps. It is sometimes difficult to use because it's very stiff, but with a rat tooth forceps, if you get the stent is out. With the rest, you lose time. And then I would like to finish by remembering these 3 giants of the history of stenting. Case Ibrecht on the left, with his cigarette in the right hand. Peter, I remember the first time, not the first time, but the second time I visited Peter in his mansion. The first things he showed me, said, this is Case, where Case comes to smoke, so if you want to smoke a cigarette, please come here. And then my mentor, Michel Kramer, and Claude Grégory, another real giant of endoscopy. And the other giant is Peter visiting me in Rome some years ago, and all the fellows that were with me at that moment were with me to meet this other hero of pancreatic biliary endoscopy. And this is the island. This is the island from a drone. So the hospital, on the island there is one church, one hospital, and 2 restaurants. Very good. So you are all very welcome if you want to come to Rome and visit us on the Isola Tiberina. Thank you.
Thank you so much, Guido. It's next my pleasure to introduce Thomas Rösch. Paul Falkins will be here, but he's late and will arrive later. And so Thomas has graciously stepped in to give us this talk. Of course, Thomas is fully qualified to do this. He's one of the expert endosonographers and a really close friend. Just a little bit of a side note, when I was struggling with EUS in the late 1980s, actually Thomas was the very first to visit me and bring me out of my bad technique and so forth with EUS. So he's been a good friend for a long time, and we've asked him now to talk about the future, to talk about interventional EUS and the future. So Thomas, welcome.
Thanks very much, Rob. Thank you all. You know, those lectures, past, present, and future, you usually get when you are well over 50, so which is true for all of us, I'm afraid. So jumping in for Paul is only natural because he's 1 month younger than I. Okay, I took Paul's slides. Was very happy to do so, modified them only slightly. You know, we know each other for a long time and mostly agree. He put the first question, why are we developing or why are we needing, what's the unmet need for therapeutic EUS? And there are a number of points like reducing the trauma to patients by using less invasive techniques, can be debated here and there. But for example, if you compare percutaneous drainage with EUS-guided drainage, it might be true. Then built on a long experience with pancreatic fluid collection, adapt, improve, expand currently available stents, develop permanent endoscopic gut-to-gut anastomosis and also other anastomosis. And that's a dream, develop pancreatitis-free biliary drainage. I think the real breakthrough came with something which was developed by Ken Binmöller, which really can be commended, and that's the yo-yo stent, the Axio stent mostly. There are other stent types as well, but Rob, this is a Boston Scientific Symposium, and of course the Axio stent is used worldwide, and it's the stent which almost all big publications are about. So we are mostly focusing on, and naturally so, on results with the Axios. Here you see that, you have seen it during the live demonstration. It's a nice principle. It's mostly easy. When you run into problems, troubleshooting can be challenging, but it's a very good principle, and really thanks to Ken Binmöller again. So, as Paul points out, main indication in the past was pancreatic fluid collection. Other EUS-guided therapeutic interventions were feasible but rare, RFA ablation, etc. I still think it's a pity that we do not have the capacity to expand the options of EUS-guided tumor therapy. Ken Cheng was playing around. The problem is it's much dependent on pharmacologic development, and introducing a new pharmacologic treatment is a nightmare for endoscope companies. So to bring these two worlds together, I think is really challenging, although it's a pity because there were some, you know, very nice techniques like magnetic nanoparticles centering around an endoscopically inserted a small magnet into the pancreas, etc., but they didn't get anywhere because it was at the end probably too complex to develop. And hot lumps was a major breakthrough. Now the anastomotic business, I think, is the main business for therapeutic EUS, as you can see here. And we'll go through the various indications briefly. The hot lumps is preferred, I would say, especially for walled-off necrosis for good reasons. I think it's much quicker and easy to perform. In principle, as we have discussed during the live demonstrations, no radiology is necessary unless you run into problems, but that's very rare. And there was an initial concern, I think, based on the data provided by the Orlando group here, that there might be bleeding complications if you leave the stent too long. Subsequent studies couldn't really confirm that. But at the end, an early stent removal is recommended, or double pigtails in true pseudocysts with chronic pancreatitis. Is metal better than plastic in walled-off necrosis? Because that's the main indication, or perhaps in the accepted indications, evidence-based for metal stents. And in fact, although I do not like meta-analysis, at least they hopefully pick all the studies which are there. And in this case, most of those randomized trials did not show a big difference. So it's not that they are very positive and very negative studies, but evidence-wise, there's no big difference. So you can debate about, simplicity of placement and performance of necrosectomy, et cetera, et cetera. So the only difference was an 11-minute shorter procedure duration, which is perhaps more relevant in the US than in other countries. Here you see an extension of a randomized trials from the Dutch working group, where they added a new lumps, and there was not a big difference, as you can see here, in the need for endoscopic necrosectomy, and also with regards to bleeding complications. Gallbladder drainage is also a topic for seemingly inoperable patients, whatever that is. I find it always difficult to say whether a patient is inoperable. These patients come with acute conditions, sepsis, so after draining them, they might turn into operable patients. And in general, when you look at endoscopic series stating we do an endoscopic therapy in inoperable patients, and a complication happens and the patient has to be operated, almost no one dies. So it's really difficult to predict, I think. And it has to be stated, of course, that cholecystitis is primarily an acute surgical indication, and there's percutaneous drainage, and there's a big debate what's better. As you can see here, a video, I'll jump over that, sorry. And here you see a study by TIO, US-guided gallbladder drainage, randomized versus percutaneous cholecystectomy. Not so many patients, but still you see the technical success and clinical success was high. And the 1 year adverse events, if you leave it in place, of course, were higher with percutaneous gallbladder drainage. And there was also a massive difference between re-interventions. So I think, Rob, your group or Chaim has raised the discussion, what happens if those patients undergo surgery? Do the surgeons freak out and have great difficulties? But there are other opinions that say, well, it's not such a problem. My surgeon would have killed me probably because he hates holes in the duodenum, but we will see. And don't forget stent exchange, as Paul points out. Gastric outlet obstruction. I think it was a very quick victory. Maybe because surgeons don't like a gastroenterostomy. And there were 2 randomized trials published recently, which you can see here from Orlando, the other one, and the first one, and the second one from the Dutch group. There were massive differences between the 2 procedures in the Orlando trial. So in a composite outcome, but also in the sub-outcomes. This was not so massive in the Dutch trial, but there was the time until patients could resume oral nutrition was much better for the endoscopic version. So I think it's pretty much, before it can be read in guidelines, it's pretty much said that this should be done by endoscopy, and from what I've heard, it was actually difficult to recruit patients for those randomized trials because surgeons didn't want to do it. So it seems attractive, and I think it will become standard of care for palliation of malignant gastric outlet obstruction. It can be technically challenging. I think the most challenging thing is, as you have seen this morning, is to find the right loop, which to make it keep still and then have the angle. Once you have done that, it's mostly not so difficult, but again, troubleshooting can be very challenging. instances where there are technical failures, so the stent doesn't open, then you can really have problems and should have some experience in management those complications. And again here, the two randomized trials. Biliary drainage. The question is, should interventional EOS replace ERCP? Given the adverse events of ERCP, which are significant. That's also interesting because usually the post-ERCP pancreatitis rate is cited at 3%. But there was a few years ago a very interesting, one of the few meta-analyses I liked, because they looked at complication rates in control groups of randomized trials under the assumption that the scrutinity to observe complications or record complications is much higher in randomized trials. And it turned out it's around 10% and not 3%. The range of severe pancreatitis was still low, but yeah, that's, I think, pancreatitis risk about 10%. We need high quality evidence. There are actually, I think, 4 randomized trials in the meantime. The first 3 ones didn't show any difference. The 4th one from Milano had significantly reduced pancreatitis rate. So what that means, we don't know yet. The pancreatitis rates were slightly lower in all trials, but in combination there was no significant difference. Another video, I think for time reasons, Rob will skip because you have seen that. And here you have one international series, which I'll also jump over for the sake of time. And then we have some questions. Who should do it? And these are Paul's suggestions that which I largely share. When you want to have a safe introduction of EOS-guided drainage, ERCP and EOS skills are mandatory, including FNA, of course. It's a new terrain, or has been a new terrain. I think it also led to the fact that the endoscopy world is increasingly split between the pancreatobiliary people and the luminal people, because pancreatobiliary is not only ERCP. In some Western centers is percutaneous drainage, is enteroscopy ERCP, and now therapeutic EOS. And if you want to master that, you probably have to focus on that area. So Paul suggests to start transmural procedures with 2 endoscopists. I mean, one of them should probably be experienced, and develop a protocol for complications. And the annual volume is a suggestion with a question mark, but it's not based on evidence as yet. That's a slide from rugby in Australia. New Zealand, sorry, where Paul was. I don't know, guys, what you think, whether that's representative for an endoscopic team. It's a little bit male-dominated, isn't it? So if you compare it with an operative room, I think it's still maybe in the past. Anyway, so what are the future needs? Rescue systems for anastomotic stents? Yes. AI-guided targeting? Maybe. I think really necessary in a few cases. But what we have been hammering on, better needles and guide wire access options, especially for transgastric biliary access, which is really an option to replace PTCD, but is technically often very demanding. And if you puncture and then, the possibilities to manipulate the guide wire are limited, so there are finally, I think, new solutions coming, as I've heard, also from Boston, but that's really a need. And then something, what would be very interesting to have something like a stabilizing working chamber of the scope tip in the GI lumen. So perhaps you could have a new entrance for nodes or something. What I mean is, if you have your access, you are often pretty unstable. So if you could stabilize that, then you would have a very nice access to do things outside, not only to drain the bile duct, but maybe if you have a lymph node in the mediastinum, you can harvest it, etc., etc. So, but that's mere speculation, and that's also the end of my lecture. Thank you.
My pleasure again to introduce Michael Bourke, a man who needs no introduction for this audience. I can just give you a little story. Michael came to Toronto back in the 90s as an advanced fellow with our Wellesley group at the time. I have to say that we almost couldn't teach him anything. He came to learn ERCP and had already done 600 ERCPs before he arrived. But the one thing we did teach him over the year in Toronto was how to speak English. Because when it came to us, we couldn't understand a word he was saying. Good night, boys. Pardon me, Michael? Oh, good morning. Anyway, subsequently, he learned English, and he taught us an unbelievable amount over his career about the colon. I mean, nobody has taught us more and advanced our techniques more than Michael has, and it's just such a pleasure to hear from you again at the podium. Thanks, Michael.
Thank you, Greg. Yeah, thank you. Yeah, I vividly remember, I think for the first 3 months, you guys, you thought I was a real idiot. I couldn't break through anyway, but it turns out I'm not that stupid, fortunately. So I'm actually going to talk more about tissue resection in the colon, because so commonly we're asked to talk about a procedure where what we should be talking about is a therapy for a problem. And so these days it should be bespoke, and I'm going to reflect on what's best practice and where we're going. And 20 years ago, and in fact when I was working in Toronto, which was 33 years ago, actually 32 years ago, everything was the same. You had a polyp, you hooked up the diathermy, and everything was treated the same. But now we have a bespoke approach, which reflects the era of precision medicine. Depending on the nature of the lesion, then it's treated in a very different way, and of course there are many different subtypes of polyps. So where we are with endoscopic tissue resection in the colon is that we're approaching maturity, and size is not a limitation. And you know, this is sort of like the usual work for us doing a normal working week. They're not all done in the same week, but we do very massive resections, and we're fortunate that at least in our area and around the state and through the eastern seaboard, the surgeons have realised that the patients are better managed endoscopically, and in fact the fellows get so excited they may even show me their handiwork while I'm trying to have the morning coffee. Nor is circumferential or longitudinal extent a problem. You can resect tumours that go 10, 15, 20 centimetres, provided you have enough time and you just follow some simple rules and you have good dexterity, good tip control. But invasion depth is a limitation, and this may yet come to pass that we have newer modalities or other means by which we can still engage with more deeply invasive tumours and effect cure. This is a case that I did 2 days ago, Tuesday morning, and I left to come here Tuesday night. Early cancer, ascending colon. We could go with EFTR, but we can also do freehand ESD, full thickness excision, if we see that the tumour is in fact invading the muscle layer. And here you see the specimen. You see a broad tail of muscle here, full thickness excision on this side, and intramuscular excision on this side, and this is the pericolonic tissues. Closure, same-day discharge. To understand polypectomy, you just need to go to the European guideline. It's all laid out very clearly in this update from 2024, how to approach these complete range of lesions. But what I wanted to do was talk about the grey zones and the emerging trends with a little bit of a case-based discussion. I'm going to talk about cold resection for serrated lesions and flat adenomas. I'm going to touch on the ESD-EMR debate, and then individualising endoscopic resection to mitigate risk, and then finally EID, ESD in the rectum, and then endoscopic resection with follow-up adjuvant therapy, which surgery could be an adjuvant therapy. It's flipped on its head, and same with radiotherapy and so forth. So this is a serrated lesion. All serrated lesions, irrespective of size, should be resected by cold snare resection. We see in some of these randomised trials for ESD that serrated lesions have been removed by ESD, which is criminal. It's indefensible if you have a problem, because the risk of recurrence is remote and the tissue is so very thin, it so easily peels off the colon, and you can end up with a very wide, clean resection. You just need to be aggressive. And here's the sublesional spot here, so sublesional tattoo. We make the resection about 1.5 times the size of the lesion. You just follow the path that you create into the submucosal plane. You end up with a beautiful resection. And here we had 34 fragments. That doesn't matter because these lesions don't recur. And we showed that when we compared hot snare resection against cold snare resection a few years ago by one of the Dutch fellows who was working with us. And you can see it at second surveillance at 18 months, the risk of recurrence is very low in either group. But in the hot snare resection group, there was 5% bleeding and there was 1 or 2% perforation. What about large flat adenomas in the right colon? So there are 3 randomised trials addressing this, but if these lesions were seen in France right now, these would be having ESD. That's just nuts, complete nuts. So what should we do? Well, we need to image them carefully, make sure there's no evidence for cancer, and we know from this study from our group that the risk of cancer in flat lesions can be very carefully evaluated, and the chance that you'll miss cancer in a flat lesion is about 6 in 1,000 cases versus 6 in 100 cases when you're looking at all comers or bulky lesions. So morphology is very important when trying to determine whether there's a risk of cancer. And sorry to offend Guido, but it's like the calzone versus the pizza analogy. You know what's on the pizza, but you don't know what's inside the calzone. Yeah, so. These are the 3 randomised trials, and they all had the same results. They're all done at the same time. This is our own big study, single centre, and then these are multi-centre studies, multi-centre European, multi-centre American. 1% bleeding, no perforation, double the recurrence rate, which was up to 20% in some cases, and no unexpected cancer. No cancer in any of these lesions included. So this is an example where you would consider hot snare resection. Mitral valve, mechanical mitral valve, on warfarin, target INR, heading towards 4. High risk of embolism if you have to stop it for a period, even if you use a Clexane window. So the best option is just to proceed with cold snare resection. Even though there's a risk of recurrence, you have a beautiful wide resection here. You can do this with an INR of 2. Just let it drift down a little bit. And actually now we're doing a randomised trial of snare tip soft coagulation of the cold snare resection to see if that can further improve outcomes in terms of recurrence primarily. Certainly it's very safe. There's no adverse events related to snare tip soft coagulation even after cold snare. And you can see here the histology, high-grade dysplasia with primarily more extensive low-grade. I include the actual histology report for everything I show so that you can be sure that what I'm saying is true, but that, of course the patient's names are redacted. So which of these cases has cancer? And the answer is none, 0. So why would they be removed by ESD? I don't know. Maybe you don't have enough work. They're all benign adenomas. Don't do ESD for benign right colon polyps. It's not justified. And moreover, if you have flat non-granular lesions which are homogeneous like these, then they don't have cancer in them either, and they can be managed by a cold snare resection. And these are cases just taken from our cohort in our own study. Of course, this is a granular lesion. The risk of cancer in granular lesions is very low, less than 1%. And of course, the other issue is that the prevalence of cancer in the right colon is only about 4% in a large referral cohort of 5,000 cases with 3,000 cases in the right colon. And the financial and opportunity costs matter. What we do need is more people having colonoscopy. What we don't need is more people having intensive interventions that deliver the same result if something's done more efficiently and safer. So the number of ESDs needed to cure one cancer in this study, where we looked at our huge experience, was 142, because the prevalence of low-risk cancer was only 0.78%, drawn from 4.4% cancer overall and 3,000 right colonic polyps. So This is how things were. This is taken from a talk I gave here in Orlando in 2012. And look at that beautiful resection from 15 years ago, actually. Beautiful. Love it. But the trouble is recurrence. And it was occurring in 10 to 15%. We looked at extra wide field resection, which didn't seem to solve the problem. And then finally, I thought of this idea called margin thermal ablation. And we did the randomized trial, which was the results were totally surprising. It was much more effective than I thought it would be. And then we went on very quickly after that, and this is published in 2021. So still, some of these centres were in the learning curve. Multi-centre international study, 1,000 large polyps, and you can see the risk of recurrence is only 1.4% at first surveillance. Of course, it's dependent on high-quality EMR, and all of these individuals trained with me. So there is a bit to doing that. Moreover, and this is really impressive, is that margin thermal ablation eliminates size as a risk for recurrence. And if you look at the era before we were doing margin thermal ablation, you see that if you have a polyp less than 4 centimetre, less than 6 centimetre, or more than 6 centimetre, the risk of recurrence is 5.2, 16.9, or 27.5%. And then after we introduced margin thermal ablation and it was standardised, it wasn't so good in the standardisation period, but once it was standardised in this cohort of nearly 500 patients, the risk of recurrence is the same whatever the size of the polyp. It's 1.4% if you have a 6 centimetre polyp. This is very important. So the next argument is, well, you've chopped it out, there's no recurrence. The final argument against EMR is, but they get cancer later. Well, they don't. So this is extraordinary data, but somehow it only managed to get a poster at DDW, and I draw you to the Kaplan-Meier curve. And you see here that this is 3,400 large polyps undergoing EMR over 12 years until December 2020. And amongst that, we chose the group with high-grade dysplasia, which is a clear factor for recurrence. And this includes the pre-margin thermal ablation. And then we have the follow-up, which is very good at first surveillance, 95%, and then it drops off as you would expect. But the follow-up goes out to surveillance colonoscopy 4 and 70 months, and over 1,333 patient years of surveillance colonoscopy, only one patient developed colorectal cancer in the EMR scar, which is a risk of 0.75 per 1,000 patient years, which is half the risk of getting Barrett's adenocarcinoma within your Barrett segment. So even though you've got this high-risk lesion, you're reduced to the situation that affects 2 to 3% of the general population. Of course, there is metachronous disease found in follow-up because sometimes it can be missed. So because these are high-risk patients, so 1% of patients did have a cancer show up somewhere else, but the risk of cancer in the lesion itself, the scar itself, is very low. But there are other lesions that definitely require en-bloc excision in the colon, and this is an example. This is a healthy lady, mid-right colon, non-granular lesion, doesn't look too bad. Doesn't look too bad. But when we look with MBI, you see here, I love the Guido. I think Guido is better than JNet, but it's JNet 2 or JNet 2B or 3 and Guido 5I, maybe a bit of N because there's an amorphous white substance there, but that could be a biopsy site. So this is a high-risk lesion. So, of course, we mark it because it's a flat non-granular lesion, it's hard to see. And actually, to save time, I do ESD with the snare tip. Now, you might say, well, but actually it's very safe because the electrode is big, and so it's hard to injure the muscle, and it's also good because you'll see here in a moment, when you have big vessels, so this takes like 10 minutes. When you have big vessels like this, you'll see in a moment, because the electrode is big, you can cut just above the muscle plane. You don't have to swap out for a coagulation mechanism. Because the electrode is big, you can coagulate the vessels as you cut through. And then you see here the end result. A little bit of bleeding. That's the final cut. And then we just close this up. Does anyone want to guess what the histology is? Lost interest, hey? High grade, yeah. High grade, yeah. Yes, high grade, yeah. So, of course, those patterns are risk factors, but not everyone's going to have cancer. I felt for sure it was cancer. What about this? This is going to be cancer. Definitely has to be cancer. But it's going to be a low anterior resection in a 63-year-old male, not so healthy. So, of course, we proceed with endoscopic resection. I'll just show you. So we start with EID, so we do intermuscular dissection, and then as we approach the point of attachment, we have to go through the muscle full thickness. Of course, avoid this big blood vessel at the back here. And because now tissue closure is so reliable, you don't need to be worried about leaving a big hole because you can close it up, whether you suture it, we just pretty much clip everything. And then the histology is very favourable. This patient is just in observation because margins are clear. It's a poorly differentiated adenocarcinoma, but no other features. So MDT recommendation is observation. The rectum is quite different to the colon. When we compare the two groups, you see that the risk of villus formation is 1.5 times greater, rectum versus colon. High grade is 1.6 times more common, and cancer is 15%, 2.5 times more common. So all of these lesions need to be treated by ESD, and in fact, probably in the sigmoid colon, a lot more lesions need to be treated by ESD as well. Whether this is done by intermuscular dissection like so, or just conventional ESD, depends really on the level of attachment. Here, this is intermuscular dissection, and these are conventional ESD. This is a fantastic technique developed by the Dutch, and also, again, very, very safe. And you can see that these are cancers, but the rest of these are just large lesions with high-grade dysplasia, whopping big lesions, 13, 14 centimetres or more. What about this lesion? So this is, again, actually a non-granular lesion, mixed lesion, looks like it's going to be a cancer. How should we remove it? We should do ESD, but we have to do intermuscular dissection. So you see here, the key thing here is laying it out with the beautiful analysis of the planes. You'll see it here in a moment. So we dissect either side, and then we can see here it's stuck on the muscle. And when we get an overview like this, we've fully dissected around, and then we just have to divide the muscular plane underneath, like so, and then the tumour comes out. You have a beautiful defect like that. Again, a cancer, but margins are clear and favourable pathology just for observation. This is the last case, and this is an important example of collaboration between endoscopist and surgeon. So this patient travelled 300 kilometres, referred by a very good colorectal surgeon. He said, look, he's going to have a proctectomy because this is a fully circumferential tumour extending over 22 centimetres from 3 centimetres into the distal rectum. So we had a careful look at it. It had an MR, there's nothing to worry about. And it looks like a homogeneous granular lesion, and some of these things grow for ages before they become invasive. So of course we do it by ESD, but we do two-tunnel technique. Just make a tunnel on one side and then another. And Haru Inui has been a godsend for endoscopy because this tunnelling for ESD is so effective. And I'll show you here in a moment, when you have a big job like this to do, and even if it's at the end of the day, this is not sped up. And in fact, once we got the plane, I usually change to a TT knife so I can go faster. This is the speed we go at. This is not tit, 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 but just cutting, cutting, cutting. Unfortunately, right at the top here is a cancer, small cancer, well, 3 by 3 centimetre. And I tried to dissect it out, but it's going into the muscle, so I ended up having to close that area. And here's a specimen. We could fully dissect off the tumour. We had to leave the cancer behind. Here's a specimen coming out of the anus, and you see the specimen ex vivo here. It's 22 centimetres long. We pin it out very carefully, and I talked to the surgeon and I proposed what we should do. Of course, I had to overcome this procedure because I did get a little bit older during, and I was clean shaven before we started. But finally the surgeon says, well, this is a cancer here. What should we do? It's just, we measure everything very carefully, mark it out very carefully, send it to our best pathologist. It's 13 centimetres from the ARJ. So we FaceTime him and he says, let me just look at the stricture. This is steroid enemas, works very well. Stricture risk is quite low. And he says, oh, that's easy. We can just do a lower anterior resection. And turns out it's just a T3 cancer, no nodes, nothing else. So, and patient's got everything intact, no stoma. I'll skip over this just to make the point that when you resect, always look carefully at the defect. If it doesn't look right, oh, there's a hole there, but you might have seen it. So, finally, a couple of years ago, I was asked to give a keynote plenary lecture at a big international meeting, and I was asked to sum up my 5 most important points. And I always ask the fellows what they think, because they tend to be smarter than me. And the guy with the worst English, who's actually Italian, Francesco Guido Mandarino, who's in Milan now, came up with these ideas. Maniacal attention to detail. Review, in-depth analysis of success and errors. Intervention algorithm for every aspect. Research orientation to feed the algorithm. Less is more. Less is more. That's very important. High quality imaging and videos. Team generating questions and sharing. Share the passion. Practice nourishes research while research drives clinical practice. And all of that had changed his perspective on research and endoscopic practice. So, as always, huge thank you to the team, and thank you for the honour of talking this symposium to Boston Scientific and to the kind people who have invited me, Rob and Chaim and G.
Thank you so much, Michael. So our last speaker for the symposium is Hisao Tajiri. He's been a wonderful friend for a very long period of time, and I think his legacy in Japan is going to be extensive. But one of his greatest legacies is really how he has helped a younger generation to help in their careers and success. He has a passion for imaging, as many Japanese do, and so we've asked to tap into that energy for imaging by asking him to talk about the present and future of endoscopic imaging. So welcome, Hisao.
Thank you, Rob. I will now present endoscopic imaging, present and future. This clip showed footage my mentor, Professor Hirofumi Niwa, recorded about 65 years ago. And it's also the Professor Rikiya Fujita, one of the pioneers of EST. This slide shows the advances in imaging technologies for gastrointestinal endoscopy. Endoscope technology has evolved roughly every 10 years from gastric camera, fiberscope to video endoscopy and magnifying endoscopy. The next major step will be the widespread adoption of AI-assisted endoscopy. ABIS-1 was a revolutionary system that allowed everyone to examine images in real time in 1985. After that, 100 and 200 series were introduced to meet different regional needs. In 2020, Olympus decided to introduce ABIS X1 as globally unified platform. After NBI was introduced to the market, I proposed consensus of terminology in endoscopy in 2008, as shown in this slide. Since its introduction in 2006, NBI has made a tremendous contribution to detection and diagnosis of early cancer worldwide. Its clinical applications have expanded to a wide range of the diseases. On this slide is the principal drawing of TXI technology. TXI is an image technology that optimizes three elements of structural enhancement: color tone and brightness correction. It's brighten image without causing hallucination. It makes it easier to recognize structural changes and slight color changes on the image and support early detection of lesions. Results from international multicenter study demonstrated that adenoma detection rate was significantly higher with TXI than with white light imaging. The superiority of TXI was confirmed not only for diminutive polyps, but also for small polyps. This slide compared NBI with NBI TXI mode in colorectal adenoma. I would like you to pay particular attention to the cyan-colored vessels, which represent deeper microvasculature. These vessels only faintly visualize NBI in the left, but they become much more distinct with NBI plus TXI mode in the light. By combining TXI with NBI, we can improve the reliability and effectiveness of lesion detection and characterization. In Japan now, a prospective three-arm study comparing white light NBI and NBI TXI is currently ongoing. In addition to the imaging technologies that I have discussed so far, currently available imaging technology in endoscopy are shown in this slide: red dichromatic imaging, linked color imaging, and amber red color imaging. This slide shows the evolution of cholangioscopy. During the past 50 years, cholangioscopy has grown from fragile two-operator performance into a dependable single-operator tool that is now centered to the diagnosis treatment of biliary disease. Since 2015, the Spyglass system has evolved into a fully digital platform with superior image quality and a simplified workflow. Continuous innovation has made cholangioscopy an essential tool for diagnosing intermediate biliary structures, treating complex stone diseases. Boston Scientific has been instrumental in driving this transformation through technology, accessories, and strong clinical evidence. Now, Civita Medical from China and Boston Scientific have partnered to develop a next-generation cholangioscope. Commercial launch in EU and Japan is planned for this autumn. Key features of new cholangioscope are smaller outer diameter and higher image quality than the Spyglass. As you know, AI is useful at every stage of the patient examination process. So we are the challenge facing medical AI. The WAI committee identified 4 key insights in its white paper: data governance and transparency, medical liability and legal issues, fairness and bias, and the paradigm shift driven by large language models. We have been discussing that AI improves detection, but over-reliance on AI may lead to dead skilling. So we should continuous education is essential to maintain professional competence. The next evolution of AI, we are now moving beyond the era of CAD-E and CAD-X. AI is evolving from a tool for detection and diagnosis into intelligent assistant that can provide expert guidance through real-time dialogue. Next generation endoscope that detect lesion in real time and propose optimal treatment strategies will become the standard. So, next I would like to discuss the next frontier in imaging technologies. Oxygen saturation imaging is an innovative technology that adds biological characteristics of tumor hypoxia to endoscopic diagnosis. By enabling real-time visualization and qualification of hypoxic lesions within tumors, OSI has the potential to contribute to the prediction of treatment response and selection of the most appropriate therapeutic strategy. Now Japan has pioneered the clinical implementation of near-infrared photoimmunotherapy for head and neck cancer. Clinical trials are underway focusing on esophageal cancer and gynecologic cancers. Moving forward, the application of molecular imaging as theranostics, which integrate treatment and diagnosis, will be a crucial aspect. So I believe as optical technology expands into theranostics, its diagnosis mission remains the enhanced detection of occult dysplastic lesions. Now I will introduce 3D imaging. Monostereo 3D endoscopic visualization system from Medical Tech from Taiwan is a novel 3D endoscopy system that performs real-time conversion of standard 2D image to realistic 3D visualization during endoscopy and has been approved for clinical use. In addition, 3D colonoscopy significantly improved adenoma detection rate, especially for flat and proximal adenomas. The benefit is achieved without increasing withdrawal inspection time. So recently, Bobro reported March contrast laser endoscopy, which built a conventional colonoscope with added laser illumination and provide multiple imaging in a single platform, such as white light imaging, multispectral imaging, blood flow, and 3D surface reconstruction. So this multi-contrast laser endoscopy represents a promising pathway toward AI-integrated computational endoscopy, combining morphological, functional, and molecular information within a single clinical platform. So the next level of AI-assisted endoscopy will fully support routine GI examinations. Light-based image-enhanced endoscopy will remain the core platform. Building on this foundation, next-generation endoscopy systems will fully integrate AI with robotic technologies, including automated insertion systems. So I think optical imaging can see, AI can augment clinical decision-making. Robotics can enable precision therapy. These convergences will define the future of intelligent endoscopic theranostics. This is my final slide. Over the past decade, endoscopic imaging has evolved remarkably from white light imaging to image-enhanced endoscopy. Today, AI-assisted endoscopy is becoming part of routine clinical practice. Looking ahead, the next major step will be AI-integrated smart endoscopy system that combine advanced imaging, real-time AI analysis, and clinical decision support. Meanwhile, robotic technology continues to advance. With the integration of AI, innovative endoscopy robots are expected to emerge within the next 5 to 10 years. We are moving from imaging to perception, from detection to intervention. Endoscopy is evolving into AI and a robotic-enabled perceptual ecosystem, with image-enhanced endoscopy remaining its essential foundation. Thank you very much for your attention.
Thank you very much, Hisao. I want to thank all of our speakers for this outstanding symposium. I want to thank my special moderator, Greg Haber, for joining us. And I want to thank Boston Scientific for sponsoring this symposium. And I want to thank all of you for your patience. It's gone a little bit later than we had planned, but really appreciate your attendance and so forth.